Hi, Dr. Phillip. My name's Andrew Roux. I'm a fourth year medical student at UMC in Jackson, Mississippi. I'm a visiting medical student here at BUMC. I really appreciate y'all having me. I've been fortunate enough to be rotating with the radiology department for the past 2 weeks, and it's been incredible. But this is my interesting case presentation, which is on a pathologic fracture in metastatic lung cancer. So this patient is a 53-year-old woman with a known diagnosis of metastatic lung adenocarcinoma. She came in complaining of sharp, worsening pain in her left ribs and back that had been going on for about a week. The pain got worse with deep breaths. She had been taking her hydrocodone more frequently than prescribed and it just ran out. She also mentioned her last chemotherapy session was 1 week ago and that she gets treatment every 2 weeks. Uh, she also denied any having any fevers or chills. Her medical history includes metastatic lung adenocarcinoma and known mets to the ampulla. She also has hypertension. Her social history is significant for a 60-pack year smoking history, but she doesn't drink alcohol or use drugs. On exam, she had focal tenderness over her left rib cage along with the thoracic spine, which lined up well with her chief complaint. On arrival, her vitals were within normal limits, and labs didn't show any major abnormalities. A chest X-ray was done, and it was unremarkable. No effusions, no cardiomegaly, and clear lung fields. Because of her history and persistent pain, she was admitted for further pain control and advanced imaging. So her CT of the thoracic spine showed metastatic lesions involving the left paravertebral regions at T8 and T9 with involvement of the adjacent ribs and transverse processes. Most concerning, as seen here, was a pathologic fracture to the left transverse process of T8. Uh, Not shown here, but also present. The scan also showed chronic compression at the L1 level and increased thoracic kyphosis at the thoracolumbar junction, which was likely from longstanding vertebral changes. In this first image, you can see the osseous changes with the arrow pointing to the um, left T8 transverse process. And then in the second figure on the bottom, you can kind of see how that transverse process is being eaten up by the soft tissue, which would be the cancer itself. Moving on to the chest CT, we see a spiculated mass in the left upper lobe, consistent with a bronchogenic primary tumor. You can really appreciate the lung nodule in this lung window here from this chest CT. A CTA of the chest was also done, which showed a subsegmental pulmonary embolism on the left side. There's no evidence of right heart strain or pulmonary hypertension. These are all these are all important findings, especially in the context of a patient with cancer, who's definitely at an increased risk of thromboembolic disease. Here's another image of the subsegmental PE in the coronal view. To recap, CT imaging confirmed a pathological fracture at the T8 in the setting of metastatic disease. The chest imaging showed a left upper lobe primary tumor with additional mets to the bone. CTA identified a non-occlusive pulmonary embolus, and then overall imaging was critical in both confirming the disease progression and guiding interdisciplinary management. During her admission, the patient was managed with multimodal pain therapy. Orthospine was also consulted to evaluate the need for any surgical intervention. Um, Palliative care was also brought on board to help manage her cancer-related pain. And for the PE, she was started on heparin drip with a plan to transition to a DOAC. Just some more discussion on the topic and learning points. This case really enforces how vital radiology is in managing patients with metastatic cancer. Imaging not only identified the pathologic fracture, but also helped evaluate for other complications like the embolus found. It really emphasizes the need for a team-based approach involving radiologists, oncologists, even orthopedic surgeons and palliative care specialists. just for further discussion and to take a step back here, bone mets are a common complication in many advanced cancers. They happen when tumor cells spread through the bloodstream and settle in the bone and disrupt the normal remodeling process of the bone. Lung cancer or cancer from the lungs, breast, prostate, kidney, and thyroid are some of the most common sources. Patients often present with pain, fractures, or even neurologic symptoms if the spine is involved. From a radiologic standpoint, METs can appear in different ways. They can appear as lytic lesions, which are seen as destructive and radiolucent, common in lung or thyroid cancers. Blastic lesions are dense and sclerotic, as seen in prostate cancer. Um, breast cancer, breast cancer can present with a mix of both lytic and sclerotic lesions. CT is great for showing bony changes. MRI is the gold standard for evaluating marrow infiltration and cord compression, and then bone scans or PET CT are helpful for full body staging of the cancer. Clinically, the presence of bone mets indicates that the disease has become systemic. This often changes how the patient is staged and treated. Management usually involves multiple specialties like oncologists, uh, radiation oncologists, orthopedics, and radiology plays a key role in the diagnosis and ongoing management. The big takeaway here is that imaging guides not only the diagnosis, but also the trajectory of the treatment decisions. Dr. Phillip, I really appreciate you listening to my presentation. I know you probably have many more important things to be doing today. If you have any questions, comments, or concerns, please feel free to email me. Again, my name is Andrew Roux, and I have my email here, jroux@umc.edu, listed below. Please feel free to reach out to me, and I hope you have a wonderful day. Thank you very much.